Congenitally corrected transposition of great arteries. Congenitally corrected transposition of great arteries is a condition in which there is atrioventricular and ventricular arterial discordance so that the circulation is physiological. Congenitally corrected transposition of great arteries is also known as l-transposition of great arteries because of the Levo transposition of the aorta. Levo post aorta forms a hump along the left upper heart border on chest X-ray. In this case, there is also mesocardia or centrally located heart. 25% cases of corrected transposition of great arteries have either dextrocardia or mesocardia. The right atrium connects to the morphological left ventricle, which in turn connects to the pulmonary artery so that systemic venous blood reaches the pulmonary circulation. The left atrium is connected to the morphological right ventricle, which ejects to the aorta, thereby ensuring that pulmonary venous drainage reaches the systemic circulation. Thus, there is a double discordance with atrioventricular and ventriculo-arterial discordance, even though it might appear that physiology of independent series pulmonary and systemic circulations is conceptually proper. The prognosis of patients with CCTGA is not that good even in the absence of other associated cardiac defects. Hence, the need for surgical correction. Definitive surgical correction of CCTGA is known as double switch. Atrial switch is by a modified Senning procedure for rerouting the pulmonary and systemic venous return. Arterial switch is done for correction of ventriculo-arterial discordance. The morphological right ventricle fails in 1/3 of cases in those without associated lesions by the 5th decade of life, while it occurs in 2/3 who had prior surgery for associated lesions by 45 years of age. This is despite the fact that a nonagenarian has presented with CCTGA. The systemic right ventricle, supplied by a single right coronary artery, has myocardial oxygen supply-demand mismatch, which can lead to subendocardial ischemia, progressive fibrosis, and overt heart failure later. CCTGA accounts for about 1% of patients born with congenital heart disease. Of these, only 1% have uncomplicated CCTGA. Commonly associated abnormalities are pulmonary stenosis, ventricular septal defect, and Epstein-like tricuspid valve. As the atrioventricular node is in an unusual position and abnormal course of the conduction system, cardiac conduction disorders are frequent in CCTGA. Atrial situs can be normal or inverted in CCTGA. Normal atrial situs is more common. Congenital complete heart block was found in 15 of the 30 cases with normal atrial arrangement in a series, but it was not seen in any of the 8 cases with situs inversus in that series. Since the atrioventricular valves are a property of the ventricles, the systemic right ventricle in this case has a tricuspid valve. Hence, it is prone for deformities affecting the tricuspid valve. In up to 70% cases of CCTGA, systemic AV valve may be displaced inferiorly, the Epstein's anomaly. This abnormal systemic AV valve is an important cause for regurgitation rather than ventricular dilatation and dysfunction. Systemic AV valve was the only independent predictor of death in congenitally corrected transposition of great arteries in certain series. The prognosis becomes poor when systemic AV valve replacement is delayed and the systemic ventricular ejection fraction falls significantly. 10-year survival after systemic AV valve replacement was only about 20% when the preoperative systemic ventricular ejection fraction was below 44% in earlier studies. In a series from Mayo Clinic, it was found that late systemic ventricular ejection fraction beyond 1 year was preserved in 63% of those who underwent surgery with systemic ventricular ejection fraction of 40% or more, while it was seen in only 10.5% of those who underwent surgery with systemic ventricular ejection fraction less than 40%. A systemic ventricular ejection fraction of 40% or less, subpulmonary ventricular systolic pressure 50 millimeters of mercury or more, atrial fibrillation, and a poor NYHA class 3 or 4 were the preoperative factors associated with late mortality. The authors recommended that systemic AV valve replacement in those with CCTGA and systemic AV valve regurgitation should be advised before the systemic ventricular ejection fraction falls below 40% and the subpulmonary ventricular systolic pressure rises above 50 millimeters of mercury.